Welcome to The Exchange, a series of rounds to drive change. I'm your host, Dr. Harsh Handel. I am the Executive Medical Director for Physician Engagement. And this series has been brought to you by the partnership between Interior Health and the Canadian Medical Association. I will provide you with information at the end regarding how you can obtain your CPD credits, and this is fully accredited by the UBC. Just to acknowledge that we are meeting on the traditional and unceded territories of the 7 First Nations of the interior. As well, I would like to acknowledge the contributions of the 15 Métis communities and the Métis Alliance to the fabric of the interior and the communities of the interior. I'd like to just take a moment to recognize that we are on unceded territory, and that the meaning of this was that this land was not given but was taken. And as settlers on this territory, we are on the path towards conciliation with our Indigenous friends. So today, my guest is a friend of mine, Dr. Paul Carey, psychiatrist and the medical director for mental health substance use. That's a mouthful for a title there. So Paul, the question today is, or the challenge today is protecting the rights of involuntary patients and getting it right. And I've always felt that the most powerful tool we had in our hands was not so much our stethoscope as our pen, in that we could take away the rights of an individual and change a person's life simply by what we write. So I'll turn this session over to you about how do we protect rights in a rights-based society.
Harsh, thank you for that introduction, and good afternoon or good evening, everybody. I will be talking to the issues of some of the ethical challenges of involuntary admission. Colleen made the point when we talked about the title of this talk some weeks ago. The very word involuntary in our current age provokes a great deal of emotion for all of us, but for different reasons. And so the question in our age of individual rights is involuntary care ethically justified? In times of crisis, our most vulnerable deserve our very best care. And the question is, what is that? I too would like to add my land acknowledgement, but I will do it from the region in which I'm coming to you. I'm a psychiatrist here out of Vernon in the North Okanagan. And I'm coming to you from the traditional and unceded territory of the Okanagan Silks people, and specifically here in Vernon, the Okanagan Indian Band. I don't know if you noted, but Harsh used the word conciliation as opposed to reconciliation, arguably because we've never been fully reconciled. So I continue, along with Harsh and many of my colleagues, the journey of conciliation for those people who we partner with in life and living and healthcare. Learning objectives today to appreciate some of the ethical challenges of involuntary care across the spectrum of conditions we treat, to understand the legal frameworks in which involuntary care occurs here in British Columbia. And then I will spend a bit of time dealing with some of the nuts and bolts of describing and distinguishing the criteria for involuntary admission for mental health emergencies, specifically here in BC. So the first part of this talk will focus a little bit on some of the ethical questions. And as with any good ethical questions, I'm not going to be providing you with definitive answers, because I think the purpose of this element of the discussion is really to focus on what some of the challenges ethically we face in the context of involuntary or coercive care. Is involuntary care really ever necessary? How can coercive care be justified in the modern age, as Harsh referenced, in an age that is incredibly rights-based? How do we safeguard the rights of our most vulnerable people in our community who may receive care at times without their consent? Who gets to decide how and when care is provided involuntarily. The UN Council on the Rights of Persons with Disability, there have been a few iterations on this Council declaration, but speak very little to the specific disabilities associated with mental illness. Article 12 refers to rights of equal recognition before the law for people with disabilities. Article 4 focuses on liberty and security of the person, really with a very strong focus on the individual, and from a medical ethics perspective, autonomy. Article 15 focuses on freedom, of the right for freedom from torture, inhuman or degrading treatment or punishment. As mentioned, there's very little attention paid to the issue of capacity or reference to specific disabilities. But from that Council declaration, the World Health Organization has developed a series of documents and standards related to the treatment of people with mental health disabilities, and specifically focused on the challenges with coercive or involuntary care. Unfortunately, mental health practitioners around the world and mental health care systems have a precarious history when it comes to the treatment of vulnerable people presenting with mental health difficulties. The commentaries related to the UN Council Declaration referenced above really don't speak very much to the issue of medical necessity, which is a founding principle when we begin to think and talk about medical ethics as we understand them, which most of you will be aware include sort of four major principles: that of autonomy of individuals, beneficence, and I'm suddenly blanking, non-maleficence, so beneficence in the best interests, non-maleficence to do minimal harm, and justice. There is a shift from the World Health Organization perspective from the concept of substitute decision-making, which is still strongly embedded in BC law, to supportive decision-making, which again continues to enhance and focus on the rights of individuals. This approach poses very serious challenges to the principle of medical ethics, which we continue to hold central to our practice. Wherein, that is the medical ethical framework, prominence is given to the challenges of capacity. So involuntary care, in the context of medical ethics, where coercive care and the right to autonomy is in conflict with what we perceive to be best interest or beneficence. Coercive care may impose harm, negative effects of treatment that might be at some level or with some perspective in the best interest of patients, but ultimately can cause harm, and cause harm in a variety of ways. And so there, a beneficent principle may in fact conflict with the right to non-maleficence. So coercive care can only be justified when the principles of non-maleficence, justice, and beneficence strongly contradict autonomy, based primarily on impairments of capacity. So by way of a practical example, because that's a little wordy and philosophical, an 80-year-old lady who gives informed consent to a surgical procedure of whatever description recovers with a post-operative delirium, acute confusional state, which is decidedly different from her baseline. She would have a significantly impaired capacity at that point, gets out of bed, walks off, and decides, I'm out of here. And so the question is, do we have the right under these conditions to hold or not to hold her? And what are the ethical principles behind that? In the context of a mental health emergency or emergent setting, a patient may present with a psychotic disorder, as an example, with pre-existing resistance to medical models of mental illness or intervention in the way of coercive care, involuntary detention, and medical management. But with the psychosis, there may be deemed to be very substantially impaired capacity with potential risk of further deterioration, risk to self, risk to the wider community or family. And this patient may be refusing all forms of treatment. So the question is, do we detain them or not detain them? And I would argue in the medical model that we follow and adhere to, the Mental Health Act legislation, etc., makes us potentially very blasé in our approach to accepting that, well, of course, Paul, in that setting, it would be completely reasonable to detain this patient. I think the purpose of today's discussion is to say those decisions, while legal, are not without substantial implications and potentially also very harmful. Potentially psychologically harmful. Involuntary detention, coercive treatment, and I'll show you a brief clip in the next few slides around how harmful and how that can be perceived by patients. The impact of that trauma of involuntary admission, I can tell you from clinical experience, can have a substantial and lasting impact on the therapeutic relationship and impact recovery, both functionally and psychologically. Involuntary admission is associated with significant stigmatization, societal marginalization, which arguably is the very tenet of what we're trying to move people away from or through. Side effects of medication, which can at times be given involuntarily and legally so, can have very substantial side effects on people and legally can be administered without consent under specific conditions.
My name's Raf. I first started experiencing mental distress in my early teens, and I ended up in quite a lot of different institutions. And initially I was supposed to go to hospital in the first instance, but I ended up on the healthcare wing of a young offenders institution before being actually transferred to hospital. The process to be transferred to hospital from young offenders institutions is a lengthy and complex one, but within that process, if you're transferred, it starts all over again. Then it's quite a confusing and worrying process. Being detained under the Mental Health Act, I think there's a lot of questionable human rights violations. So my personal experience, just to name a few, for example, some of the violations I felt were around kind of strip searches. In some cases I was strip searched up to twice a day, long periods of time in solitary confinement, freedom of movement and autonomy, inability to practice religion, which is, I feel, a fundamental right of anybody. Being detained under the Mental Health Act, I often felt kind of discriminated against. So when I was praying in my bedroom and a member of staff who may not have had that kind of cultural or religious knowledge accused me of speaking to myself or talking to myself or reacting to voices, which kind of caused that conflict, which actually resulted in me not being able to access the community on that week. I think solitary confinement in any form, however you call it, whether it's called an extra care suite, whether it's called seclusion, I mean, these are all just fancy names for solitary confinement. You're in a room with nothing in a cell for up to 24 hours a day in some cases. At one point I recall spending a year straight in solitary confinement. In my personal case, the impact that it had on my mental health was profound, in terms of psychosis being exacerbated, in terms of just not having anybody to speak to. A lot of being in hospital is very coercive. Either you do this or you can't go out. Do this or you can't do that. Take your medication or you can't go out today. It's very coercive and very restrictive. Trying to refuse treatment in hospital is a little bit like requesting to go to solitary confinement or requesting to be restrained or forcibly medicated. I mean, over the years, I guess I have grown a lot of resentment for the way that I was treated, but that resentment is also led into kind of a flame, if you like, of wanting to be able to help change what is happening within institutions and particularly mental health services today.
We know that studies show that functional outcomes are improved, that long-term relapse prevention is correlated with short durations of untreated psychosis, and we see long-term lower rates of death in this population. These conditions and these ways of achieving those outcomes come at significant cost to people. One of my patients said to me when I was doing some quality improvement work on the Mental Health Act, "I'm in such a frail state, please treat me with care. I'm still myself somewhere inside." She tells me after 15 admissions over the course of 2.5 decades, secure treatment may be necessary, but it still feels like torture. And that kind of comment continues to both haunt me, but also give me pause on a daily basis when I'm with my pen, referring to Harsha's easy comment, writing the order for coercive treatment of this nature. The next video clip I'll show you comes from some of the World Health Organization documentation from a colleague in the NHS who will share with us some of his experience. And really what I'm wanting to show you with this is and cultivate within us is the questioning of and awareness, growing awareness of and empathy for what our patients are going through. But I also want us to think about, in ordering coercive care in whatever shape or form, the extent to which or the degree to which I'm mindful of my own motivations for those orders. And I have to confess, 20 plus years into my career, that there are times when I suspect that the orders may have been driven by elements of fear that really spoke to my own challenges in the situation and may not always have been as ideal as I would like for the patients that I'm treating.
Consultant in the home treatment team and the clinical director for adult services. We co-founded Promise together. So I'll be following Naomi's fingerprints with footprints of my own. What I'm about to share with you is not something I've done in a big forum like this before, and it's quite personal. 22nd June 2006, I was a specialist registrar in Oxford, working in an assertive outreach team. My team contacted me to engage in a Mental Health Act assessment. The patient concerned was someone I knew quite well. I'd seen him about a month or so back, and I believe we had fairly good rapport. Family had become increasingly concerned that he was getting unwell, he had stopped his medication, was more paranoid and suspicious. He had a past history of violence and aggression, so the team said if we're going to do a Mental Health Act assessment, we should involve the police, and the police attendant, two kind of policemen came with us. So we went to this person's house, the mother ushered us in, a social worker, myself, a GP, his GP, and a GP trainee, and 2 policemen. The 2 policemen stayed outside. We went in, we sat down. He came, was quite happy to see me actually, shook hands with me, and sat down right beside me. It was one of those settees into which you sink in. The social worker started explaining why we were there, and suddenly, from the corner of my eye, I saw a fist coming towards me, and it landed on my lips. He was training to be a boxer, and he packed a punch. It was like one of those Hollywood movies where things tend to slow down. Blood splattered everywhere, kind of glasses kind of gone somewhere, dropped the notes, tried to get out of the settee and seemed almost paralyzed to get out of the settee, and he was shouting abuse from like a foot away from me. Managed to get out. The policemen were the first to run away. They were off. Anyway, I ran out of the door. I could hear him kind of screaming behind me. I could hear his mother pleading him to stop. The police were on their radio. The verbal tirade continued for another 5 minutes or so, and within 5 minutes, the two vans turned up and took him away. So the police were very responsive. From there, it was back to base, and because I was pretty banged up at that point, my consultant said, right, you have to go to A&E. So we went to A&E, where I got violently pushed and prodded by a junior doctor, who I thought did me more damage than the initial assault. And she said, oh, I still remember the expression on her face that I want Max Fax to take a look at you. And I could barely speak by that point, not letting anyone touch me. And anyway, the Max Fax chap came. X-rays did not show any fractures, but he kind of announced pretty royally that, well, there's no blood supply going to your teeth at the moment. Your gums are so swollen. So by tomorrow, your tooth would have become non-viable. The front four, at least the top incisors, they will turn black over the next few months, and you will most probably lose them. So at that point, I couldn't care less. I just didn't want anyone to touch me on my mouth and push me and prod me. So went back to the base. My consultant told me not to drive. Of course, I drove back home. So when I got home, my wife, Mon, was, she was pretty disturbed to see me in that state. But anyway, I didn't want to talk about it. It's a different matter. I couldn't speak as well because my mouth was so swollen. My in-laws were visiting from India. I was very embarrassed that they saw me in that state. I remember lying down beside my 11-week-old daughter, Mahi. I graphically remember the softness of her touch and the comfort I found in that. And I was physically and mentally exhausted, but I just couldn't fall asleep. It was not so much that the assault was playing on my head. It was more that I thought I had a good relationship with him, and how could he have done it? There was a breach of trust, and that kept playing through my head. Anyway, I must have drifted off at some point. Next morning, I was quite resolute not to get underneath my skin. My mouth was even more swollen next morning, so I stayed indoors. The day after that, the swelling went, and well, 10 years on, thank you, Mr. Registrar, I still have my teeth. They haven't turned black, so they're still there in one piece, in case you were wondering whether I've got faults too. I did not want this to get to me, so I think it was 4 days' time, another Mental Health Act assessment came up, and I said, right, I'm going to do this, and I'm going to get it out of my system. Unfortunately, even in that Mental Health Act assessment, and it's damn bad luck to have 2 assessments like that, there was a lot of violence. The chap had a glass ashtray, he threw it to the wall, which smashed into a million pieces, chased the social worker down the hall, and kept kicking the door of the office. And police were brilliant. They responded within 2 minutes, and he calmed down very quickly when the police turned up. And that second incident really shook me. And for a long time, at least for 3-4 months, I was quite anxious around difficult clinical interactions. A slight change in someone's voice, and I could feel my heart racing. Thankfully, it's been 10 years, and I haven't had any such overt aggression since then. There have been many difficult clinical conversations, a lot of the time using coercion subtly to get people to engage in home treatment so that we don't have to bring them into hospital. But I haven't been at the receiving end of such aggression. It's been a long time, but I still find myself getting quite emotional talking about this. Of course, this is my own perspective. It must have been very different from the patient perspective about how it must have felt for him, how alone must he have felt, knowing that his family had been in cahoots with these people who are going to take him away. We had turned up with clear intention to take his liberties away. And it was, recovering from this was a fairly lonely affair, because as a doctor, we kind of don't really talk about stuff like this. We just get on with it and somehow pull up your boots. So it was a lonely affair, recovering from this. And it was in that loneliness I started to develop empathy for what the patient would have gone through and how lonely must he feel. Yes, staff who are carrying out the Mental Health Act assessment would feel they're acting in the best interest of the patient, and they're acting out of necessity. And often family also are in agreement with that. But that's not a perspective that's available to the patient at that point in time. So that kind of, when you look at it in the cold light of day, it seems completely unprovoked. But was it unprovoked? I was the one who had turned up at the patient's door with police. He was a boxer, so he responded in the way he knew best. Of course, I'm not saying that anyone deserves to be assaulted in the line of their work. No one does. But somehow being able to reframe it allowed me to kind of make sense of what the patient's world would have been like. My own incident has helped me empathize with a lot of what our staff actually go through every day, being at the receiving end of violence or irritability or aggression. And that makes me even more resolute in making the case for promise, in making the case for change, because coercion breeds resentment and frustration, and it's our frontline staff who end up getting that back. To this day, I wonder whether, whether he knew what he was doing. Our colleagues on dementia wards tell us that they often get hit or assaulted by patients. But they say that there's something in the fact that patients are not cognizant of what they're doing, which perhaps makes it more bearable or forgivable. There's a part of me, quite a big part of me, which feels that it doesn't matter. Well, it might have been that he was unwell, but he knew exactly what he was doing. And one can ask, why does that matter? Well, it matters because the pain and the physical trauma does subside fairly quickly. It's the breach of trust which actually takes a fair bit of time to recover from. Your ability to engage in caregiving without feeling anxious, that takes time to recover from. And when I look at my emotions, what really stands out is kind of shame. That's what stands out, which is a bizarre emotion to have around this. Why shame? Perhaps I should have known better. Perhaps I should have seen it coming. Perhaps I should have been feeling anxious for those 3 months that I felt anxious about. I guess emotional responses are different for different individuals, but everyone arrives at the same kind of point. Why did it happen? Now, we can reason it away as the patient was unwell or the patient was inherently aggressive, but that would be a lost opportunity to not ponder over the fact that what it must have felt like to be the patient in that scenario. If you were feeling suspicious and paranoid and your family had gotten behind your back and had got police and a group of individuals to take your liberties away, would you then feel trust in getting care from these people who you think are perpetrators? I wonder, our patients, do they feel shame like I felt after they have been at the receiving end of coercion and force? It's taken me 10 years and a lot of pushing and prodding from Sarah to come out and tell this story. Responsibility of leading promise has churned all of this up. How many stories like Naomi's or mine remain untold? The hope is that the promise qualitative study would capture these stories, give us new insights which will form the fingerprints of empathy, and if not being able to walk in each other's footsteps, perhaps patients and professionals can follow each other's footprints. With that, I would like
I think there are a number of quotations that we could ponder on from one of them, certainly that the perspective of what was happening was simply not available to this patient at a particular time. We might somewhat unemotionally say he lacked particular insight. I think the question is, does your care of our most vulnerable have the fingerprints of empathy of what our patients may be going through in those difficult moments? In this case, more typically referencing some of the mental health emergencies that we see. Does your care possibly of our most vulnerable sometimes reflect our inherent fear, both for self and for others, or our fear of perceived outcomes? Is it balanced with the right to safe, trauma-informed care? I did let you know I might be asking more questions than I'm answering this afternoon. I'm going to shift gear for the last couple of minutes of our talk and time together to talk a little bit about involuntary care. And I'll focus first on what got us going down this pathway some year or two ago with the Auditor General, Ombudsperson, in BC, releasing a report on the state of involuntary admission under the Mental Health Act here in BC. Very significant increases in the last decade. And the framework, the legal framework that defines the defense of rights for patients when involuntary admitted, involuntarily admitted was shown to be very, very far from the standard of what was expected. So a lot of the documentation that we are required to fill in as physicians was incomplete or absent entirely, not done in a timely way, complemented by some of the deficiencies in other areas of Mental Health Act documentation that was required. And so part of this and part of the work that we've been doing is responding to some of the recommendations around training, modifying, standardizing, and providing training to those who exercise rights under the Mental Health Act. We worked with a group of family physicians. We worked with patients to complete this work, and I'm not going to go through that in detail. I will be sharing with you when you do your assessments of this session some of the resources that I've used to put this together. This is a slide taken from a recent BC Medical Journal article providing a framework for an understanding of involuntary care. And I'm not going to go into all the details, but let me say this much, that patients who present with acute undifferentiated illness, typically medically, who are lack capacity, again, a medical ethical principle, and in this jurisdiction, where a substitute decision maker is required or is not available, involuntary treatment, meaning without consent, to save life or limb or prevent serious harm or outcomes, is permitted legally. And the legal framework for that is the Healthcare Consent and Care Facility Admission Act. That's a bit of a mouthful, and I will give you that reference and resource to go and look at for yourselves. That really provides treatment, medical treatment, for people in an emergent situation. Just as a point of reference, for people who present with a psychiatric or behavioral mental health emergency, who are in an outlying and smaller emergency department, and you are deeming them to be certifiable, meaning they require transfer to a designated psychiatric unit in one of the larger centers, it is under the Healthcare Consent and Care Facility Admission Act that you are typically admitting these patients. You complete a Form 4, they're not technically certified at that point, but they are involuntarily detained under this act. There is no formal documentation to sort of assert that, and the advisory committees on which I've had the pleasure of continuing to serve is looking at putting together documentation with the leadership of the ministry to help people feel more comfortable and to ultimately receive education on how best to manage these situations in order to use the Mental Health Act in more appropriate settings and the settings for which it was specifically defined, which is primarily and frankly exclusively for mental health emergencies. I'll come back to that. The Adult Guardianship Act is another piece of legislation that really specifically focuses typically on people who are vulnerable to abuse and neglect or self-neglect, is focused on adults, and specifically those who are vulnerable, and meaning not able to seek and or receive assistance when they're at significant risk of deterioration. But it's not the same level of emergent situation. And again, typically is also what is another principle that is central to this is the issue of capacity. But I would commend you to that article. In our own health authority, in a survey that I completed, emergency room physicians and psychiatrists alike really are not completing the quality forms under the Mental Health Act to a level of quality that meets the standards. The combination of these renders only about 10% in the study frame that I to be valid, meaning both Form 4s were completed to the standard, suggesting that 90% of the people in that sample frame were actually illegally detained when based on the documentation, which is an alarmingly high figure and puts all of us, our patients, their families, ourselves as physicians and the health authority at significant risk. They were often illegible, single-word criteria lacked detail, specific risks were seldom provided, unclear reason for why people are unsuitable to be treated as voluntary patients. It wasn't in patient-friendly language. Some people write tomes of information that frankly is irrelevant to the criteria, with some of the qualitative measures that came out of that survey. Next couple of slides, I'm just going to run through the basic criteria for the Form 4 and the Form 5, which is the consent to treatment. There's a bit of information here. I don't expect you to have all of this to hand right at the end of this. These resources are available, and I will show you some links to that are available on our Inside Net. The patient in question, I don't want you necessarily to read all the detail, but a middle-aged man who presented to the emergency department with depression, suicidal ideation, with a plan, some intent, an opportunity, was not consenting to treatment, albeit not violent and resistive, had previously stopped treatment, had a suicide attempt in the past, which he minimized. So Criterion One in the Form 4, just physicians' names, the date and time is crucial. There isn't a time field in the current iteration of the form. I'm pleased to say that these forms are being revised and will be legislated in the coming months. The time frame is still uncertain, and we're hoping that in a PDF format there will be some force functions within the fields to address the 4 criteria. So Criterion 1 really relates to the question of, does this person have a disorder of the mind, which is legal terminology for the core presenting symptoms or the presumed diagnosis. And we say something when we get to issues of risk and why inpatient treatment may be necessary, because someone can be depressed with suicidality and have a plan, but ultimately be able to say, using these resources, accessing this treatment, I'm comfortable to continue to work collaboratively with you as a care provider. And under those circumstances, involuntary admission wouldn't be justified. So in this particular case, as I've just quickly summarized for you, suicidal plans with intent, a refusal or a dismissal of the care plan opportunities potentially put someone like this at risk, requiring inpatient treatment. Past treatment of risky behaviors, absenting themselves without leave, not taking treatment as indicated or felt to be necessary to preserve life and limb or to minimize risk, etc., is what is sort of being referred to in this criteria. And finally, if all of those above criteria are met, the patient is still unable to accept any form of treatment that has an evidence base of being suitable and ideal evidence base for a good outcome, that they would not be suitable as voluntary patients in that context. These forms are filled out within, at the time of admission, and the second Form 4 within 48 hours of the hospital. Very briefly, I'm going to run through the somewhat paradoxical sounding consent for treatment for involuntary patients. Really, this is about evidence of rights and discussion of patients' rights and awareness of what they're going through, even if they do not necessarily have full capacity at the time to consent to this treatment. But many of our patients who are involuntarily admitted are in fact able to appreciate some elements of their treatment plan and are able to acknowledge that that has been discussed with them. So in that case, the patient would sign this form once we've described the treatment plan, and the physician and a nurse who's a delegate under the Mental Health Act would sign that. But in other cases, patients are unable to do so. And then we do go through the consent discussion. We're required to do that by law. The nurse delegate of the hospital would sign that, as would the physician. And then we would focus in the description of the treatment on 5 or 6 criteria that are crucial. We talk about specific reasons for admission, what the goals of admission are, what the target symptoms are, classes of treatment we'll be using, non-pharmacological therapeutic approaches, We are explicit about whether restraint, coercive treatments in any shape or form will be used, and that is outlined in that form. So moving forward, I think, the shared responsibility we have in this work is that this is profoundly impactful treatment that is legal. And we need together to be committed to changing the elements of the system that we have influence over to make sure that our most vulnerable are protected. Each of you can be involved in your way at your local site, whether it be with inpatient units in the ER or on medical floors, to work with your local site staff to make the quality of the care and the evidence of how we deliver that care better. It's really supporting a culture of review and revision and being ready to look at your own practice. Our care can be, and one of the messages today, both simultaneously essential, legal, and harmful. Does your care of our most vulnerable have the fingerprints of empathy? And does it reflect that empathy as we continue to confront these very challenging situations?
When you have the brain injured individual, and there's almost a sort of trying to calm yourself down, check your own pulse, instead of reacting to what's happening with staffing. Any thoughts in terms of that at all when it comes to this? Because it's so easy to get caught in a cyclone.
Yeah, absolutely. And I think, Harsha, the situation as you describe it, and I think the reason for the second video clip is I think we need to recognize that these kinds of situations that provoke fear, some shame in us as clinicians because of how we've managed some of these situations or felt about them, can resonate for months or years beyond these incidents. And that we are very susceptible as clinical teams in an emergency situation to be responding out of fear, out of sometimes very unhelpful emotions to bring about safety. One of the advocacies that the WHO, and certainly is a standard within our largest sites, and where we have challenges is where these teams don't exist, is that we do this work better in groups, in teams of people who are adequately trained, are skilled in the tasks of structured approaches to these very volatile and unpredictable situations. So in colloquial terms, we call this violence prevention, de-escalation techniques, using a trauma-informed approach. Specifically, we have code white responses in our designated sites or larger sites. And these are teams of people who are trained to help make sure that there aren't one or two people who are the sort of the sharp end of the stick in a situation like this. And so that approach has been shown with abundance of evidence to be the most helpful in de-escalating and redirecting these responsive and reactive behaviors. Because the reality is we need to acknowledge, and I hope, part of sharing these experiences is the fact that these situations are frightening, they threaten us, and we can't be our best selves when we are fearful like this. Having that shared experience does an enormous amount to dissipate that fear and help us do better work in these critical situations.
There's a question here for you, Paul. From what you said, the Form 5 has to be completed in the first 24 hours. So if we fill out the Form 4 overnight in the emergency department, can we leave the Form 5 until the morning when the psychiatry team reviews the patient?
There has been a lot of back and forth from the ministry on this question. And I will tell you that at this point, the Mental Health Act standards document, which was published by government in December of last year, leaves us a little bit gray. And the short answer is it says, in technical terms, the Form 5 or consent to treatment needs to be completed when treatment is initiated or within 24 hours. So I have specifically had direction from the ministry leads on this to say it is reasonable for someone who you detain involuntarily in a site, a designated site in this case, with a Form 4, to leave the Form 5 until such time as the psychiatrist, who is arguably better placed to put together a more comprehensive treatment plan, to complete that at the time that the second Form 4 is completed. This is open to interpretation, and what I would say is there is absolutely nothing stopping you completing a Form 5 at the time that you complete the first Form 4. But legally, and what we're auditing is that this is done within the first 24 hours. So you can do it. It would seem not to be essential. And that's the message that I'm giving, because I've not had direction otherwise at this point.
Another question is, if a patient was brought to the emergency department with concerns and threats to attempt suicide by the family, and the patient denies the plan or the intent to act in the emergency department, is the collateral evidence, the testimony of the family, enough to certify someone or to prolong an opportunity to assess the mental status and symptoms of that person?
The short answer is that you still are going to need to do an assessment and make a judgment call. So it's a very difficult question to answer generically, because there are so many complexities to the doctor-patient interaction that are going to inform how you make a judgment with respect to your interpretation of the veracity of what this patient is saying to you. So it's a complex question, and I would say you may or may not. It's as an example, and what I would say is, if a patient, most families would not. I mean, I've got very few cases that I could think of in 20 years where a family have brought patients to hospital with a history like that without good grounds. Because, as we saw in that video clip, that has potentially very destructive and substantial impacts on family relationships. So when families do bring people, I certainly, we should be paying serious attention to that, number one. And in the patient assessment, I think part of the process is to assess to what extent is the patient cognizant and aware of the concerns that the family are expressing. How do they interact with that information? How do they provide some sort of description of how they may have felt like that or not, and where does this come from? I confess that I would tend to err on the side of caution, and I might be more willing to admit someone like that involuntarily based on the history that I've received, and then reassess the next day. Difficult question to answer because there's so many variables to that, but the short answer is it's legally possible to do so. Yeah.
Thank you, Paul. Where do you hope things will go? How do you hope things will develop over the next 5 years as you're so involved in this work?
Again, Harsh, there are many layers to that question. I think in the immediate future, we are continuing to advocate for some standardization of the education that physicians are required to take to be registered and to be working with patients where the Mental Health Act comes into play. So jurisdictions abroad, UK, Australia, New Zealand, require certification courses to be able to exercise rights under the Mental Health Act and require that to be renewed every 5 years. We are working towards a standardized curriculum and expectations to do that and to renew that on a regular basis. We are continuing to work to mandate, if you like, some shorter form of that education when physicians here in Interior Health come on board, both for those who come from other jurisdictions where the Mental Health Act legislation is different, as well as those who are obviously coming from abroad. So that would be sort of the early piece. I think more broadly, we continue through work like this to sensitize people to the risks and the psychological effects of trauma and trauma endured at the hands of care providers. There are disproportionate numbers of our Aboriginal patient partners who present to our mental health facilities, and the propensity to aggravate the already existing context of multi-generational trauma for these people is incredibly difficult. And this is a particularly sensitive area in which mistrust and mistrust of the healthcare system can so easily be perpetuated. And so I think within mental health care, within our emergency departments designated sites, we have an unusually sensitive responsibility in conciliation as we continue to try and deliver culturally safe and appropriate care in the right setting to patients and families. So those would be some of the basic tenets. I think we have a lot of work to do to continue to promote least restraint policies and safe and trauma-informed de-escalation and patient care in our acute care sites.
Thank you, Paul. With that, I'm going to wish you a good night and I just raise my hands to the work that you're doing. And I'd like to thank you all for attending tonight. The exchange has been brought to you by the Canadian Medical Association in partnership with Interior Health. We hope you will join us for future sessions, which is on a third Wednesday of every month. And lastly, please take care of yourselves. As Paul pointed out, and as his videos have demonstrated, there's actually trauma to the caregivers involved in these situations. So thank you and take care. Good night.